All right, so another Thursday in the books, and we have 10 studies to get through. So this is going to be a bit more of a rapid fire session. Starting off, we've got cervical flexion posture with smartphone use was not a risk factor for neck pain, but other things found in the study were, which are correlated with smartphone use. So the actual physical act itself, according to the study, doesn't seem to increase neck pain, i.e. staring down at your phone. Now, is that still something where now it gives us an excuse like, oh, it doesn't cause my neck pain? Well, then why do I still have it? I look at my phone all the time. Well, it seems to be that the behaviors associated with extended smartphone use are what's really the culprit when you're using it too much, especially at night, because low levels of physical activity, which I think is more than a few of us, even if we want to admit it or not, and low sleep quality, which is also associated with, I know I'm not the only one who once in a while it's 11:30 and your smartphone's still on in the middle of the night in bed. So really, is using your smartphone a cause of neck pain? Well, both yes and no. The physical mechanical factors associated with the cervical flexion does not seem to be the culprit behind neck pain and smartphone usage. However, the behaviors associated with excessive smartphone usage, i.e. poor sleep quality and low levels of physical activity, are. So in one ways, yes. In one ways, no. Smartphone use is not a cause of neck pain, but its behavior association is. Next up, this one is the efficacy of high velocity, low amplitude thrust manipulations, i.e. adjustments, whether they're done by a chiro, physical therapist, DO, etc., in patients with radiculopathy, a systematic review with meta-analysis. This one I might see if I can steal and just keep in my own bank, because this was pretty cool. So they searched databases and they wanted to see if there were randomized controlled trials comparing adjustments to different interventions in patients with cervical thoracic or lumbar radiculopathy. So pain that will radiate somewhere else, i.e. if it's in the neck, it'll radiate into the shoulder, arm, elbow, wrist, etc. If it's the low back, it'll radiate into the glute, leg, calf, foot, etc. And they had to make sure that the studies had some sort of an outcome related to pain, disability, range of motion, or health-related quality of life. They pooled the data. They wanted to look at a risk of bias and all these different things and synthesizing it. And what did they find? 11 trials met the criteria. Adjustments were associated with significant pain reduction compared to sham, and no recommendation intervention at all in both cervical and lumbar radiculopathy. Adjustments were associated with reduced pain compared to conventional physical therapy alone, keyword is alone, at short and medium-term follow-up. No differences at long-term follow-up, which no surprise given the purported effects of the actual adjustment itself. The overall risk of bias, however, was high. So even though it says great things, we have to proceed with caution. Now, again, clinically, when done right, I've seen this when I was an intern, I've seen this as a doc when I'm dealing with patients like this. Is it the be-all, end-all, i.e., is adjustments the thing that'll cure radiculopathy? No. Is it, when you screen for the right patient, doing the right intervention at the right time, absolutely fantastic for the patient in front of you? Oh, yes. And so that's what I think we need to say about this study is some of the key things were you shouldn't be fearful about getting an adjustment from a well-qualified, well-trained practitioner if you have these conditions, because it can clearly help. You still have to do the recommended and what's the word I'm thinking of? Standard of care when it comes to radiculopathies, which will include some form of lifestyle modification and or rehab/physical therapy. So that's why I said the key word in this one is compared to physical therapy alone. And just understand that the risk of bias is high. So that means that a lot of people might just try and oversell you on it. And that's just what I want to make sure we don't do. We understand what this is saying, that it's great, but there's bias associated with some of these results. So we can use it. It shows good efficacy evidence so far, but don't rely on somebody overstating and overselling you what this tool does and saying, oh, I can cure that radiculopathy with just adjustments. Well, short and medium term, maybe you'll get a lot of bang for your buck, but nothing else will be long term compared to other interventions. So you still need to do other things in addition to manipulation, or see other people that are doing different things to get you a more comprehensive level of care like you could get at our office. Now, this one, since we're talking about adjustments, there have been some claims out there that certain interventions, whether it is specific adjustments, which we could get into an argument about with other studies, and or utilization of tools and specific techniques when you're utilizing adjustments, can have beneficial effects on things like heart rate variability. And this study basically compares the instrument assisted adjustments of the upper cervical spine compared to a placebo. So they really wanted just to, well, let's get some of our vocab down. So in this study, a randomized clinical trial included 64 participants with a wide age range with acute or chronic MSK pain. The intervention group, so IG, received a single high velocity impulse on the bilateral transverse process of C1, while the control group received a placebo. Okay. Now, especially when you're utilizing instrument-assisted adjustments, it is much, 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 much easier to introduce a legit sham adjustment, because all you have to do is set the impulse to 0. The instrument will still make a sound. The instrument will still be contacting the segment, but nothing will actually happen. There isn't any actual force being delivered into the joint. So it is a legit sham adjustment, which is why it's great when you're actually studying. Does it do something when you're actually comparing it to a sham study? While the control group received placebo, heart rate variability was recorded with pre and post intervention using the Polar H10 monitor. So that's a chest strap that goes right across and measures your pulse rate. It's one of the great low cost ones. Like, it is a gold standard straight to consumer heart rate monitor, and it's what a lot of other devices like Aura, Whoop, etc. will compare their heart rate monitors against, because it's the OG. It's still great because it only does one thing, and that's all it's supposed to do, and it's great with that. And so what they saw was both the actual treatment and the control group had a heart rate variability score differential. So the intervention group showed a significant change, and the control group had a significant change within the group comparisons. No differences were found in between the groups as far as what they were measuring for heart rate variability. So that basically means that instrument-assisted manipulation did not significantly change the heart rate variability compared to placebo, indicating that it is likely external variables in the setup that changed the heart rate variability. So this could be the patient's anticipation. This could be the sound. So the patient presumes that when the sound is generated, that the treatment was rendered, therefore they should be improving. So there's a lot of external variables with why patients may get better or worse. Like, context is king. There is a lot of placebo in all realms of healthcare. We see this when we're, discussing studies that involve placebo medications, as long as it's sold the right way. We see this with interventions on a conservative front, just like this one, needling versus non. Like, there is a ton of placebo that you have to presume is going to be in any treatment that deals with people, like people to people, and expectations with a treatment will have some sort of an outcome, will have some sort of an effect on the people being treated. It's just the way we're wired. It's the way our brains work. It just is a really fascinating concept, actually, when people say, oh, it's just a placebo, and patients can't get better with placebo. And quite frankly, I don't care if that's your perspective. Like, if you're telling me that I shouldn't do something because the only benefit the patient will get is a placebo benefit, that's still a benefit. So it's like, well, that doesn't technically do this. It's like, well, yeah, but the patient is comfortable with it. It's part of their expectations coming into a practitioner that they see for this condition. And by meeting their expectations, whether or not there is legit physiological or mechanistic reasons that the patient should get better, if I'm doing what they think will get them better, by definition, the way our brains work, it will improve any potential treatment that I have with that patient, and I have a greater chance of getting them better overall. So I would rather understand how human interaction works, how placebo can be utilized for the betterment of my patients, and not care and worry about all these nuanced things about, well, that's only placebo. Your point, as long as we're taking an ethical, evidence-informed approach with the patient, and we're including a treatment that will not harm the patient, and I know that it's going to do nothing, mechanically or physically for the patient, but they want me to do it, there's a very good chance that I will, because I understand that I might get a placebo benefit. And that is still in the betterment of my patient in front of me. To me, that is still ethical practice. To me, I am agnostic about what approach will get my patients better as long as it gets them better. Okay? Now, hopefully that'll be the longest article that I actually preach about, but moving on. Conservative treatments of carpal tunnel syndrome, a systematic review. This is one where they just, again, it's another data synthesis one, 49 randomized controlled trials involving 11 different conservative treatments, and 3,000 participants were included. The analysis showed that manual therapy demonstrated the highest efficacy in both short and medium-term pain relief, with surface under the ranking curve values of high percentage values, essentially. They also looked at dextrose injections and PRP. They were a close follow-up to manual therapy. Low-level phase laser therapy and extracorporeal shockwave therapy also had significant benefits. So these things, well, minus the dextrose injection, but these things, manual therapy, I can prolifically do in the office. I have access to other practitioners who have low-level laser therapy as well as extracorporeal shockwave therapy. All of these things have fantastic results when we're dealing with a legitimate, tried and true carpal tunnel syndrome, which means you don't have to just jump to the surgery. Like, we should take a ton of steps prior to surgery. It's not, hey, I have numbness and tingling and maybe some pain from, my wrist into my hand. I'm going to go see the surgeon and have them, cut my hand and decompress that area. Well, you better be lucky enough to think that that's the only level or area of compression, because if the median nerve or any of the nerves that innervate your hand are trapped or gummed up in the works upstream, i.e. in the forearm, elbow, biceps area, shoulder, or neck, cutting your wrist and decompressing the wrist isn't going to cure it. I've had several patients where that was the case. But there are a ton of avenues that if you have a median nerve compression, i.e. carpal tunnel, or one of its cousin diagnoses, where one of the other nerves in the forearm, etc., other places that I listed is compressed, manual therapy is a fantastic first level, low risk, affordable treatment option for this condition, as well as the low level laser therapy and the extracorporeal shockwave therapy. These are things that you can try at typically a comparably very low cost to surgery to see if it will actually give you relief and more or less treat the carpal tunnel. So if you have carpal tunnel, come into my office. Let's make sure we have the right diagnosis. If it is carpal tunnel or one of its cousin diagnoses, let's start you off with a conservative trial of care. And if we feel you need an adjunctive therapy because manual therapy either isn't doing it, but we have the right diagnosis, or it's not going as fast as we want, we can rope in and collab with the other providers that I have in my back pocket that have the lasers, that have the extracorporeal shockwave therapies, and let's get you better before you have to go under the knife. Next up, there's going to be a few on TMD and BPPV here, but I'm going to go relatively fast because they essentially say the same thing. Dietary habits and the risk of temporomandibular disorders, a randomized control study. 10 dietary habits were found to be significantly associated with TMD risk. Protective factors included in these studies: muesli consumption, so that's kind of like a warm cereal, a warm grainy cereal, fresh fruit intake, and decaffeinated coffee. Hey, I'll take it. Even if it's decaf, I'll take coffee and red wine intake. But that one, for me, I would say proceed with caution. I don't think that one is causative. I think that is lifestyle. The people that drink occasional glasses of red wine versus other alcoholic beverages typically exhibit different lifestyle behavior patterns compared to those that would drink hard liquor or beer. So I don't think that's necessarily causative. I think that's correlative, but that's my bias on this in this interpretation. We'll move on. Risk enhancing factors included consumption of white or brown bread, so frequent consumption of white or brown bread, cornflakes, Frosties, low-fat spreads, and complete sugar avoidance. So it's just like, oh, makes sense, makes sense. You know, the standard American diet, sad diet, makes sense. But wait, complete sugar avoidance, why is that? Well, something that I typically see in my office is the absolute abstinence from a food group does not necessarily yield the benefits that we want it to, because the substitution factor of how we get the makeup version of the calories will then have as bad of an impact on our health as avoiding the quote unquote bad food item to begin with. What do I mean by that? Well, let's just take a look at this sentence. Complete sugar avoidance means you're likely dipping down the amount of very, very good tasting, highly processed, non-nutrient dense foods are. So more or less colloquially termed empty calories. So you're eating less flavorful foods and you're getting total less calories. Well, from a mental standpoint, yeah, the tasty part is a bummer, but the subconscious part is going to be that reduction in total calories. Your body is used to a certain amount of calories, and we aren't as a culture great with dealing with hunger. So you are going to typically subconsciously increase your total calorie. You're going to actually try and maintain the amount of calories that you're eating before the total sugar avoidance, which means you're going to substitute in other food groups. And if you're not conscious about that, by directing yourself towards very healthy foods, you're going to do it with what is around the house. And that could be the low-fat spreads, which you can still add up and it adds in calories. It could be in things where the sugar is avoided, but now you up your fats, which are more calorie dense than the sugars themselves. So that's why it's paradoxical when you look at it just from a glancing point of view. But when you think through it, it's like, okay, that still makes sense. If we're just listening to Instagram or TikTok and avoiding all sugar without understanding what your body's going to naturally do and setting yourself up for success, you're just going to put yourself through some misery and not see the results you want. Now, that is this study as far as associations. Next up, link between diet and painful TMD, cross-sectional studies. This one was 92 participants with 20 to 50 age range in Spain. TMD was based on this criteria. Dietary data was collected through a 24-hour recall and assessed with the Healthy Eating Index, HEI, and the Dietary Inflammatory Index, basically a bunch of different indices. My only issue with this is that it's a 24-hour recall because it is 11 o'clock when I'm recording this. I can barely remember what I had for breakfast. So not, in my opinion, a gold standard. You'd rather have somebody directly track this as they do it, but hey, I'll take it over nothing. Results. TMD patients showed significantly higher scores in various symptoms, depressive symptoms, maladaptive behaviors, while no significant differences were found in the, which one was it? In the Dietary Inflammatory Index or the Mediterranean Diet Adherent Index scores. The patients still had significantly lower Healthy Eating Index scores and values, okay? So again, another one that is correlating dietary patterns with TMD issues. Where I think I had, let's go with this one because we're going to transition into BPPV, but this one is still dietary. Exploring the association between BPPV, hypothyroidism, and metabolic comorbidities, a retrospective case control study. So what they found was 140 individuals were diagnosed with benign paroxysmal positional vertigo. So one of the non-scary reasons that you get vertigo or dizziness. Patients with BPPV demonstrated statistically significant higher odds of hypothyroidism. So that I'm not necessarily saying is dietary. It's just a fact that we have to deal with, and it shows itself a little bit higher prevalence in the female population. But this one, diabetes mellitus, no, it doesn't say type 1 or type 2, but The incidence rates of type 2 is definitely on the rise, and that has a ton of lifestyle factors that are associated with an increased risk of developing it. So we see TMD, diet and lifestyle. We see TMD, diet and lifestyle. Now we see BPPV with, granted, diabetes mellitus, but diabetes mellitus also, especially type 2, has significant factors with diet and lifestyle. And it was compared to national estimates. No significant associations were found for hypertension or osteoporosis, but still, if you have metabolic disorders, in this case, diabetes type 2, I'm just going to say diabetes type 2. I know it just says diabetes, but I'm just going to lean towards diabetes type 2 to make my point. And you have other autoimmune conditions, you're more likely to develop BPPV. Now, other things that put you at a risk for developing BPPV, prior head trauma. In this study, I think it was, let me jump down to results, covariates, tables, discussion, results. While the actual, in 30,000, I think, let me make sure I get this right, because they actually pared it down quite a bit. It starts here. Among clinical variables, head trauma occurs slightly more in the BPPV group, 2%, well, 2.3% versus 1.8, suggesting a potential clinical link. So they said, okay, let's dive a little bit deeper. Let's see, rather than new onset head trauma, let's see if there's a prior history of head trauma that actually will illustrate if prior injury causes a risk. So they started in this paragraph here. Although the absolute difference in prevalence of head trauma between the two groups is small, the difference rates is real and clinically relevant, and that head trauma can dislodge the otoconia, so little ear crystals in the inner ear, potentially causing that BPPV. So they wanted to investigate whether prior head trauma increases the odds. And they found was analysis showed that prior head trauma was significantly associated with increased odds of BPPV by almost 30%. Okay. That is pretty big. So if you have prior history of concussion, head trauma, you banged your head really, really good, you maybe need to see somebody for it, you have a higher chance of developing BPPV, in which case, come see me. I know we can treat you just right when it comes to these conditions. Frankly, all of these conditions. Beyond the splint, efficacy and safety of kinesiotaping for non-operative management of finger injuries. I like this one just because, I use tape in my office. I use dynamic and KT tape. And pretty much most studies that show efficacy of KT tape can show efficacy with dynamic tape. And if we can get somebody moving safely and we have evidence showing that it is as safe as an intervention as a straight up cast, all the better. Like the more movement we can get safely, all the better. 175 patients were randomized into 3 treatment arms, a KT tape, buddy taping, so taping 2 fingers together, and splinting. Participants were then broken up into peds, 5 to 18, and adult, 18 to 60 subgroups. Outcomes like range of motion, grip strength, and a disability indice were assessed by independent orthopedic surgeons at 3-week and 3-month follow-up. Baseline demographics were comparable across groups. Group 1 demonstrated statistically superior outcomes with significantly greater ranges of motion, lower disability scores, and higher grip strength relative to splinting. Group 2 exhibited intermediate efficacy, outperforming splinting, but remaining inferior to Group 1. Subgroup confirmed consistent therapeutic advantages for KT tape in both pediatric and adult cohorts. So it's emerged so far in this study as the most effective modality when you're dealing with non-operative finger injuries, such as ligament injuries. Okay. Now, last study, almost done. Breath-back connection, a systematic review. This one's basically saying they wanted to see through the literature, what did it say about diaphragm function and low back pain? So studies assessing the function and thickness of the diaphragm, abdominal muscles, and lumbar multifidus during breathing in individuals with back pain versus healthy subjects were included. 14 studies met the criteria, 8 case controls, 6 cross-sectionals. It indicated variations in diaphragm thickness, excursion, fatigability in low back pain patients with inconsistent evidence regarding its function. So basically, it couldn't really agree exactly on what, when, where, why, and how. Abdominal muscle activity and recruitment patterns differed significantly between low back pain patients and healthy controls. I think that's a bigger key factor here. with altered TRA, transversus abdominis, and internal oblique activation. Some studies reported increased transversus abdominis and internal oblique thickness in low back pain patients, potentially compensating the diaphragm. Again, they're leaning on a bit of a stretch here, while others reserved reduced thickness and activity, and that's why I think they're going on a bit of a stretch. Lumbar multifidus size showed no significant differences during breathing. Cool. So what does this all mean? Well, I think, like I said before, it's this sentence right here that is really the potential link between why there is a difference in breathing and muscle recruitment between back pain patients and controls. I think when you are going through back pain, your body develops different strategies about how to navigate the world. It will put the brakes on sooner during certain movements and kind of try and have you avoid things that would trigger the pain. So you're going to be working around, pushing through, doing different things to accommodate the pain signal that will lead to an altered muscle recruitment pattern. And that can also show up in how we utilize our core, including the diaphragm. So I think it's one of those things where it's not so much a factor of strength, like, oh, you have a weak core, therefore, if we improve your core strength, we're going to improve your back pain. I think it more has to do with restoring proper communication and prior movement pattern recruitments that will actually help the patient restore and improve their actual pain. Because they're, how do I phrase this? Because it's going to go on the internet. While I think that strength is one of the absolute best things we as a species can pursue to reduce a whole bunch of factors associated with all-cause mortality, we can reduce the likelihood of sarcopenia, osteoporosis. We can improve metabolic factors just with lifestyle factors associated with the pursuit of strength, like reductions in metabolic conditions, disorders, et cetera, like diabetes. We could basically reduce the incidence rates of a metric ton of our current chronic diseases by the pursuit of strength. When it comes to pain, I think we have to be realistic and not say that strength will automatically improve it. The lifestyle factors associated with it, the pursuit of it, the goal of it, can certainly give you the best odds of improving a lot of these conditions, but I don't want to say it is causative. What I want to say is people will alter how they do things when they're in pain, and if we restore that prior baseline setting where your brain was like, I moved this way when I wasn't in pain. I had access to these muscles. I had access to this pattern prior to pain. I think if we're able to pursue that communication change, we have probably a better potential cause to cure their low back pain or manage their low back pain accordingly than the absolute pursuit of strength. Put another way, while I love deadlifts, somebody in acute low back pain, I'm not going to necessarily have them deadlift at their 1 rep max. Do I need to avoid it? Maybe not. It depends on the patient and how I go about communicating what they're doing, giving them ideas on how to either work around the pain in the short term to give the body time to kind of recoup and assess what resources it has at hand and kind of let the brain and body calm down a bit. Or I can try and go about it and restore the person's prior, most likely prior pattern to their previous norm so that the brain basically does the same thing. Then it's like, oh, I'm back in old territory. I'm back where I used to be before pain. So I'm not as likely needing the pain signal. That's right now the best way I can describe it. I'm sure there's going to be other studies where I have a little bit more coffee in me and I'm not quite as rambly about it, but I hope that made sense. If you have any questions about that, feel free to leave a comment, stop by my office, let's have a chit chat. But until next time, thank you for sticking with me so far.